You and say thank you for joining us. I am Trish Hutcherson, Orion Health Corp's Marketing Director, and I will be with you throughout today's session as your moderator. On behalf of everyone at Orion, we hope you enjoy today's presentation. And before we get started, I'd like to run through a few housekeeping items. Today's phone lines will be muted for the duration of this session. If at any time you have a question throughout the presentation, please enter them into the GoToMeeting dashboard on your screen. Technical or logistical questions will be answered in real time. However, questions related to the content will be answered at the conclusion of the presentation. We will be offering a Q&A session, so please feel free to type questions in throughout the entire presentation. Also, as a quick reminder to all attendees on the line, you will receive a copy of the slides at the conclusion of the presentation later this afternoon. And with that, I'd like to introduce today's speakers. Max Reibold is President and CEO of Coker Group, a national healthcare advisory firm. Max possesses over 40 years of total experience, with the last 20 years specifically focused on healthcare. He has experienced firsthand the incredible changes of healthcare providers, which uniquely equips him to handle strategic, financial, and management issues that health systems and physicians face in today's evolving marketplace. A graduate of Harding University, Max is a licensed CPA in Georgia and Louisiana, and a member of several professional organizations, including the American Institute of Certified Public Accountants, Healthcare Financial Management Association, American Society of Appraisers, and the American College of Healthcare Executives. Amy Greeter is a senior manager at Coker Group with specialized experience in alignment, strategic planning, accountable care responsiveness, compensation, mergers and acquisitions, operational issues, financial management. Amy focuses on working with nonprofit and for-profit hospitals and health systems of all sizes and larger single and multi-specialty physician practices. She's a popular program speaker and is frequently engaged by highly respected organizations across the nation. Ms. Greeter attained a Bachelor of Science in Human Biology with honors from Michigan State University, but don't hold that against her, and a Master of Public Health and Health Policy and Management from the Rollins School of Public Health at Emory. And with that, Max and Amy, go ahead and get started whenever you're ready.
Okay, Trish, thanks very much. This is Max, and Amy will be joining me momentarily. I'm going to kick off the presentation today with a few introductory remarks and cover the first few slides, and then we'll tag team it. The title of our session today is How Specialty Groups Can Thrive in the Accountable Care Era. It's interesting, we use this term accountable care era to encompass a lot of different things. It really entails everything from the ACOs themselves to entities that are coming on strong that we'll talk about today, consortiums between physicians, private groups, hospitals, etc., clinically integrated organizations, as it were. So we'll talk a good bit about that today. Actually, I've turned now to slide 2 with the agenda, and you'll see we're going to cover several pertinent areas today as it relates to this topic. We will focus our comments on specialty groups, both multi and single specialty, and at the end of our session we'll provide a case study which is a real-life example of some things that we've experienced in at least one or two instances, one in particular around the country already. We'll talk about an overview first, and so let me move into that. I think everyone is aware, as we look at slide 4, that cost, reimbursement, and access to health care continue to be challenges. And I think probably more than anything, these three are the driving factors as it relates to the Accountable Care Act, other legislation that has been passed, and indeed all that we're going through in the healthcare industry today, and even more specifically in your practices. Costs continue to rise, and we've got to get a handle on cost in the healthcare industry at large. Reimbursement is also, needless to say, a challenge with the continued cuts from Medicare, the private insurers looking at reductions on a regular basis, and contracting being much more challenging. Access to health care is also an issue. We have more and more individuals, not the least of which are my era, the baby boomers, entering or soon to be entering the Medicare coverage area, expanding Medicaid, and of course a lot of individuals that heretofore have not been insured that will become eligible for such coverage when the Obamacare legislation really kicks in 2014. So these changes are truly unprecedented and things that we're all going to have to be dealing with in the healthcare industry. Now, as such, we are looking at a changing paradigm in this whole accountable care era. At this point in time, and as we work with hospitals, health systems, and large groups in particular, like you, specialty groups in particular around the country, we're finding that most everybody is still living in what we call a fee for volume, or fee for service is what it's often called, environment, meaning that you're compensated based upon the level of work, the volume of work that's completed, as opposed to some other metric. Now, this is changing, or at least it's supposed to be going to change, and change a fair amount. We believe that fee-for-service is not going to totally go away, so you'll still have an environment that includes some element of fee-for-service. But on the other hand, as ACOs and clinically integrated organizations become more prominent, I think we're going to see payments from the payers, including the government payers, that are bundled. And indeed, then the providers of health care will have to work together, either in a collaborative or perhaps under an employment arrangement, as many physicians already are, of a health system, to really then decipher and, if you will, divvy up the reimbursement from a bundled payment. Moreover, a lot of this reimbursement, and again, this is more in theory, although some of these things are actually coming to play in certain instances, but we're also going to see a fair amount of the reimbursement tied to some form of a shared savings program, which is conceptually tied to an element of quality and metrics of quality for performance. So we're looking to really change the paradigm, as this slide 5 indicates here, moving away from episodes of care to more of a utilization management environment, moving away from a disjointed provider base to one that is aligned, and indeed then to receive payments in accordance with that. That's really the accountable care era healthcare delivery model, and like it or not, that's what our industry is moving to. So the realities, as you see here on slide 6, are that we're continuing to experience burdens as individual, independent practices. That is not to say that private practices will go away. As a matter of fact, I think with many private practices coming together in independent practice associations that will, at least in concept, potentially become a clinically integrated organization, private practices can certainly continue to survive. But at the same time, they're going to have to deal with these elements that are about to become even more present in our industry, such as declining reimbursement, continuing to pose threats, the loss of reimbursement of ancillary services, etc., as you see here on slide 6. All of these pressures are on private practices, and as a result, they're having to develop a strategy to really deal with this. Now, again, that is just automatically moving to employment with a health system. In a few minutes, Amy's going to share with you some concepts relative to different models of physician-hospital alignment, and I think that will become even clearer when she does that you don't have to move directly into employment. But we do recommend that some strategy for alignment and ultimately what we call the stage 2 of this whole paradigm, and that is some form of clinically integrated strategy will have to take place. There are opportunities as some of the things are starting to come into place. Medicare is actually accepting some new CPT codes for care coordination, and these allow physicians to receive payment for the management, the continuum of care, as it were. And so this really captures or encapsulates that concept that we're talking about, incentivizing providers to improve quality of care and really to provide them through a continuum, similar to, I'm sure, what everyone is familiar with regarding a medical home type concept. And even some of the specialties like OB are looking at medical home type concepts for this continuum of care, again, obviously for women's care throughout a lifetime, literally. And so all of these things are in play. We definitely have the issue of the aging country that's in play. I guess as you see here on this slide 7, there's good and bad news to that. There will be more demand as we're living longer and aging as a country, but needless to say, that also prevents some challenges as we could have workforce shortages and, of course, just a glut, if you will, on the market. As we all know, the longer you live, the more health care you consume. So these are the things that are out there, pretty familiar. We could look at the glass being half full or half empty, I suppose. We prefer to look at it as half empty, creating a lot of opportunities, but it is for sure going to require a lot of adjustments that perhaps we haven't had to do. And those adjustments are going to be potentially most demanding and challenging upon the physicians themselves, the individuals that I suspect most, if not all of you, work for, as do we. So the accountable care era as it relates to physicians, just continuing on with that thought as to why they really are looking at alignment. And of course, alignment means different things, but in an all-encompassing manner, it's really whatever form of integration, affiliation, you name the word, as it relates to collaborative efforts with other physicians, other providers, including health systems. And you see the reasons here on slide 8. I think these are pretty commonsensical, so I'm not going to really cover them one by one as such. I'd rather move into some of the more newer things that we're going to share with you today in this presentation. So accountable care era trends, as we call them, really come down to a consolidation and really this whole concept of strength in numbers. One of the books that we wrote in our firm about 3 or 4 years ago was really entitled Strength in Numbers, and it was really all about this concept and how physicians and hospitals and really all providers of health care are going to have to come together and are going to have to realize that they're no longer, if they ever were, actually I prefer to say they never were adversaries, but they're certainly not going forward, that we're going to have to work together as it relates to dealing with all these challenges and even the opportunities. These things are really in play here as it relates to the future. I think that virtually every practice, large or small, single or multi-specialty, primary care or specialty, really doesn't matter, needs to have an alignment strategy, whether that's to be employed, which is okay, by a health system, to merge with a larger group, to become a part of a multi-specialty group, to become a part of a clinically integrated network where you can remain private, maybe starting out as an IPA and then evolving into a CIN. Those are all options. And as we move into the next section of our presentation, Amy's going to start to drill down a little bit more on those options. Amy?
Thanks, Max, and Trish, thanks for the warm introduction, and I won't hold it against you and where you went to school either. It's all in good fun, everyone, I promise. So as Max said, we really see there being a push for alignment as part of the overall healthcare delivery system and certainly the accountable care response efforts that every practice is being tasked with these days. However, I will be quick to say that we see alignment as only being the stage 1 of the overarching strategy, and stage 2 really becomes that focus on accountable care and clinical integration. When we talk about alignment, we try to do what most people do, what most consultants do, and that is give it an easily recognizable language. And I've done that here on this slide, and I'll share it with you. We categorize the various alignment structures that are in play within the industry right now into 3 buckets: limited, moderate, and full. And the example I always give when I'm giving talks is that limited forms of integration are basically dating. They're ways for organizations to come together to learn about each other, but not necessarily have that ongoing commitment that comes with some of the moderate or certainly full forms of alignment. In keeping with the analogy then, moderate forms of integration or alignment are what I always say is they're the engaged. You've picked your partner, but you haven't necessarily walked down the aisle. You have some commonality, you have some shared vision, but it isn't until full integration, the marriage stage, where you really have tied yourself significantly to another partner. And I always say I'm happily married and have been for a number of years, so full integration, marriage, isn't necessarily a bad thing, but it is definitely a significant commitment between two parties. When we look at specific examples of alignment structures that fit within each of these three categories, you see them listed on slide 11. Limited forms include things that we're all likely very, very familiar with. Pay for call, unassigned ED call, assigning administrative time, medical directorship time for which physicians are compensated, providing recruitment assistance. Moderate forms of integration, again, a lot of familiarity here with these type of structures. We look at joint ventures between various parties. Good example of that in the last several years has been the development of specialty hospitals, which could be various physician groups coming together or even physicians and hospitals coming together to create the entity. We also see MSO or ISO services, and then finally we see some specific service line management opportunities, either through service line management or through the more encompassing clinical co-management. And then finally, we get into examples of full alignment. Employment, obviously, is a very common methodology right now, although I will tell you, hospitals are starting to get smarter, and I don't say that in perhaps as degrading of a way as it comes across. But hospitals are getting smarter in the way in which they employ physicians. So new models like the physician enterprise model or the group practice subsidiary model are becoming alternatives to standard W-2 employment that are becoming more attractive and more palatable to physicians. The intent of the PEM and GPS and similar models of employment are that they bring a practice under the umbrella of the hospital system, but it's in a way that really preserves a great deal of the autonomy that's currently afforded to the practices in private practice. And the reason for that is that many practices don't want to surrender their autonomy when they move towards employment. I have a group that I'm working with right now, multi-specialty practice in the Northeast, and they are very, very concerned about giving up all of the things that they enjoy right now, the management of their staff, their clinical decision-making, their business decision-making as part of an alignment transaction. They are going to move forward with employment, but they're going to do so under the PEM model, which is going to continue to allow them the opportunities that they so currently enjoy. Now, one of the struggles with these newer models of employment is that not every hospital is wise enough yet to what they include, meaning sometimes it takes some education on the part of the practices as to these alternatives. But again, hospitals are getting smarter, so I like to think these days, and many are expressing an openness to even the newer forms of employment. We also see various forms of full integration like employment light. So employment light is just a common language which often refers to professional services agreements, a contractual relationship between practices or individual service lines within a multi-specialty practice and a hospital or health system partner. And what these allow the practice to do is to remain intact as a private practice entity, but have this contractual relationship with a health system partner. When we look at the bottom of the list, and other forms of full integration that we're seeing now within the last 2 years are things like accountable care organizations, clinically integrated networks, and quality collaboratives. And really, we're going to talk about each of these models a little bit further, but on the next slide, we're going to see that the ultimate goal of each of these is to really look at clinical integration as being the goal. And again, it's regardless of whether you define that through an ACO structure, a CIN structure, or a QC structure. But the ultimate goal is really to enhance the patient's experience of care, to improve the health of population, and to reduce or control the per capita cost of care, said so eloquently by the IHI in their triple aims. Now, as we look at newer models, we look at things that Max alluded to earlier, patient-centered medical homes, quality collaboratives, CINs, and accountable care organizations. I'm going to spend some time drilling down on the quality collaboratives and the clinically integrated networks now. To clarify between the two, quality collaboratives are typically the larger umbrella structure that affords a type of alignment between two parties. Quality collaboratives often have a keen focus on quality, unsurprising, for a defined population. What I will tell you is that in contrast to clinically integrated networks, which often have both quality and cost efficiencies as part of its entire scope of service or scope of focus, quality collaboratives typically have more of a central focus on, again, unsurprising, the quality aspect. The next slide shows you an integrated delivery system with a lot of moving parts. But in essence, the moving parts that are portrayed in slide 14 are meant to define what we call a truly integrated system. Don't be put off or assuaged by the amount of moving parts. Instead, I invite you to embrace the totality of care that can be provided when all the various constituents within an integrated delivery system are working in tandem. And that truly is the focus of a quality collaborative or a clinically integrated network. The next slide shows an overarching generic structure for any type of collaborative organization. You'll see here that we define it as a CIN, an ACO, or a quality collaborative, because this general structure works regardless of what structure you ultimately want to go for. What you'll see is in the black box, there is this model that we're all striving to achieve, and it can come from various ways. What we see is that it's imperative that you have physicians participating in the model. Now, what you'll see in these various structures is different methodologies for engaging the physicians. In many models, you have contracted primary care physicians, you have contracted specialists, and you often have employed physicians as well if you're engaging our hospital or health system partner as part of this overall initiative. The next slide drills specifically down to a hospital-sponsored collaborative. I'm going to take one quick second here to tell you a little bit about what we're seeing in terms of hospital-sponsored initiatives versus physician-sponsored. If I was talking to you 18 months ago, I would have told you that the only viable scenario for collaboration or alternative was to truly engage a hospital partner. And the reason for that had many aspects. But one of the biggest was the perceived deep pocket that exists with hospitals or health systems. There will be a need, and depending upon the scope of your organization or the structure you create, for capitalization. And that can be a difficult pill to swallow for many physician practices. I was on the phone yesterday with a large physician group, amalgamation of various entities in the Southeast, talking about their potential for collaboration that was excluding a hospital partner. And what I told the physician with whom I was speaking was that it's certainly possible, but you have to have a way to financially support the organization, and certainly for the near term until your organization is up and raising funds to be self-sustaining. So again, 18 months ago, the hospital-sponsored collaborative was seen as really the only opportunity as a result of the need for collaboration. What's happening now, though, in more recent days, again, exemplified by the call I had yesterday, is a lot of physicians are pulling together, pulling their resources together, pulling their brain power together, and coming together as larger groups to sponsor their own initiatives. Regardless of the need for capital, physicians feel that they have the wherewithal, certainly the brain power and the economic power, to be able to really and truly develop these in a way that's successful. And one of the ways that they think that they can do it is that they can be successful in markets where these type of initiatives are not being undertaken by hospitals right now. And although we talk, I think everyone in the industry talks a big game about accountable care and clinical integration, a lot of systems have been reticent to put their dollars where their mouths are and move forward with these initiatives. It can be a very burdensome task. It can be an overwhelming task. And so in markets where there is a deficiency or a void of these hospital-sponsored initiatives, physicians are working together to really develop their own initiatives. On the next slide, you'll see an example of a payer-sponsored collaborative. Certainly, we see that right now. I have an example of an organization that has contracted with United as their large payer in their market. And United is helping drive a lot of these initiatives for collaboration. The whole focus is to include not only the physicians or group practices, which remain independent, but also bring in multiple hospitals and health systems which are served by these practices to really look at overall ways to improve health within that community. Slide 18 then goes and portrays an example of an IPA organized collaborative, what I just spoke to just a moment ago, which is physicians and practices that are getting together. What we all saw was the PHOs and the IPAs of the 1990s, a lot of them went defunct. We're now starting to see new life for those type of entities as we set up these collaboratives or alignment strategies. So certainly, again, another very viable alternative. On the next slide, regardless of what alternative you pursue, whether it's quality collaborative, ACO, CIN, there are some components that are going to be a requisite to ultimately get the structure off the ground. First, and at the top of the heap, the biggest bar, the greatest way that we can provide it with the most significance, is to involve physicians in the leadership, in the decision-making roles, in the planning and development for any initiative that you're going to want to undergo. I can't underscore this enough. This cannot be led by the group practice administrators, although usually they have a lot of the tasks thrown on their shoulders, but you have to engage physicians in the process. Inter-provider and inter-practice alignment. Again, a lot of practices right now are turning towards other practices, creating some of the strength in numbers and really moving forward of their own accord. Next, complementary structures to hospital strategic partners. One of the difficulties that I have seen in the market right now is physicians that are trying to go at it alone on a divergent path to the health systems in the market. So rather than engaging with them as partners in the overall initiative, they've set off on a course that's divergent from whatever the health system's goals are. This creates difficulties for a number of reasons, and it also creates significant difficulties in getting the structure off the ground and the longer-term success of the relationship between the parties. Finally, provider communication and coordination, and this really goes at the bottom of the pyramid, which is the information technology infrastructures. Not only do they need to be robust, they need to be coordinated. It's very, very difficult in the age of accountable care and clinical integration to pull off a structure that doesn't have information technology supporting the overall enterprise. We have a client whom I absolutely adore, I will tell you, but believes that it's certainly possible to engage in a successful clinical integration strategy without having some way for the information technology systems to talk to each other. In fact, they believe that using fax and other what I would call antiquated methodologies for those physicians who aren't even on an electronic medical record system will be an acceptable way to transmit data. I dare say, again, although I thoroughly enjoy this client, that is not going to be a viable strategy. It just is impossible without having some way for systems to really and truly talk with each other. What I'm going to do now is turn it back over to Max to talk specifically about the CIN and CIO alternative structures and what they comprise and what we've seen as how you get these off the ground. Max?
Sure. Thanks, Amy. And we'll continue on with this discussion. And I will say, if you have any questions that you're thinking about, just go ahead and be prepared to send them downline, and we'll certainly have several minutes left to try to cover them. As Amy indicated, we're going to talk now about clinically integrated networks and organizations. I think the key takeaway here at the very beginning of this discussion is that private practices, and I perceive that that is, if not all the audience, that's certainly the vast majority of our audience today, is comprised of individuals from private practices. I think you have, obviously to this point, you and your physicians have made this decision that you're going to remain private, at least for now, that you really value that independence, that autonomy, that ability to provide care for your patients in a private setting. And yet you're probably, after hearing our, at least some of our comments today, you're thinking, well, is this something that we're going to be able to continue to do? As Amy indicated, 18 months or so ago, it looked pretty bleak. Moreover, we were actually, as consultants, telling a lot of our clients that it's virtually inevitable that just about most every private group, with the exception of some of the real larger ones, are probably going to ultimately be a part of a health system. Indeed, there are a lot that are, and certainly we have many examples where we've worked with hospitals and private groups where that's still the case. But having said that, there is clearly the opportunity to remain private, and as such, you can form or be a part of your own clinically integrated organization. Just in the past 2 to 3 weeks, and I don't know, maybe it's coincidental, I don't think it is, we have had numerous calls, interest calls, calls of interest, etc., along the lines of private groups, consortiums that are either already formed or about to be, or certainly thinking about it, that are looking to do this kind of on their own. And often they are emanating out of an IPA, an Independent Practice Association, and actually we think that's a good idea. Some of the slides that Amy shared with you on some of the models in the previous section indicated, in fact, 1 or 2 of them, I think it was slide 18, actually showed the IPA or the PHO as one of those entities that's a springboard into contracting with an ACO or CIN. So let's just go ahead and look at a couple of slides and try to illustrate what a clinically integrated organization is. By the way, the term CIO, CIN are pretty much interchangeable. The primary focus of this clinically integrated entity is to create the high degree of interdependence among all the participants. Now, the slide 21 that we're looking at is what we often call our three-legged stool slide. Now, why is it that? Well, because at the bottom, and quite frankly, it doesn't, it could vary as to who's at the bottom, but in this example, we're looking at an allied network of providers, and typically that's an alliance of specialist and or primary care groups. You really probably need both, and they could actually form the CIN. You will need to partner with a hospital or multiple health systems in your clinically integrated network, and moreover, other providers of care that fill out the continuum that we've been talking about pretty much all day today. So all of the providers will be aligned, but not necessarily does that mean that the providers have to be employed. Now, under the hospital circle there to the left, you could have employed physicians. That's fine. But typically, the model that we're illustrating today, where it's a privately formed CIN, those allied network of providers that typically emanates from an IPA, as I said a moment ago, will then come together and clearly have to have the quality, the capital, the financial wherewithal, and the technology to pull this off. To the top northeast corner is a very important circle, and that's the payers. The payers will be contracting, and this is the commercial model. This isn't the Medicare ACO model per se, and I should have said that at the beginning, but that's really what we're focused on. But the contracting mechanism vis-a-vis bundled payments, shared savings, and indeed fee-for-service could, or I should say will come from the CIN to the payers themselves. This will be the look of the future. And that's why every single private group needs to find a mechanism, a CIN of sorts, upon which to align. If the group's large enough, you could probably do your own network and just contract directly with the hospital who forms the CIN, or possibly even directly with payers. So there's a lot of mixing and matching here, and needless to say, a few unanswered questions still. Continuing on with the thought, though, I must emphasize, as Amy has already done very well, that there's going to have to be a strong IT infrastructure, and that's expensive. I was working with a group just last week where we're helping to form about a 350 physician clinically integrated network, all private practices in a state in the South, and essentially the final stage of pulling this all off and becoming clinically integrated is to develop this robust disease registry and disease management information systems. Again, you've heard the term population health management. This is what we're referring to here. Well, in order to do that, you've got to have a strong IT infrastructure, interfacing of softwares, if not the same software. That's expensive. Matter of fact, I told this particular group that they would probably be looking at a 7-figure total that they would have to come up with in terms of capital to be able to effectuate being clinically integrated. So the opportunities for specialists, as we literally turn the page to slide 23, is that you can be aligned with a hospital, you can be aligned through a CIN. Actually, you could be aligned through multiple CINs as a specialist. Primary care, of course, in the Medicare ACO model can only be a part of a single ACO. To my knowledge, there's no legal prohibition for primary care physicians in a CIN, a commercially payer-driven CIN. So there is, in fact, again, a lot of mixing and matching that will be going on. Let's talk a little bit about risk and challenges of integration. Clearly, there's going to be more and more competition come down for how these things are pulled together. I'm sure many of you are thinking, well, shoot, I don't want to be the practice that turns out the lights, in the room, so to speak, and is the last one. I want to, but then again, I don't know that I want to be the guinea pig on these CINs either. Moreover, I don't know that I have enough private practices that have enough vision, excuse me, to come together and form a CIN and to do these things. And I'm not sure about the compensation model and how that's going to be done going forward in a competitive environment. You see the slide section here on antitrust. That's still in play, and I will tell you from personal experience of having clients that have been challenged with antitrust regulations upon their alignment transactions that you're going to have to be clinically integrated, just like the IPAs that were not clinically integrated years ago that were deemed by the FTC as being illegal. This is still in play as far as we know. So all of these challenges, and in fact, if you want to call them risks, are existent. Continuing on with that thought, we're going to continue to have more and more regulations. We're used to that. I suspect that there's going to be even more focus on enforcing regulations from the OIG to the FTC, and oh, by the way, those two are not necessarily congruent in their beliefs and the way they interpret what's going on in healthcare, if you know what I mean. And we're going to have to sort those things out, and needless to say, involve legal counsel, very competent healthcare legal counsel to assist us. Operationally, there will clearly be challenges, not just in IT, which we've already talked about, but really just the whole issue of governance, day-to-day operations, revenue cycle management. We're looking at a significant change going on, probably more than we've ever encountered before for those of us who've been in healthcare a long time, and even for those who've not been in healthcare so long. Now, as far as the path to integration, and this is by way of a bit of a review right now as we wind down this presentation. Amy alluded to this earlier. We believe that the first stage of your strategy vis-a-vis alignment or integration is to really look at a alignment strategy relative to your practice and to a hospital or hospitals. Again, that does not mean that you have to become employed, but it does mean that you should look for and develop a strategy. It may be that your strategy is to merge with other groups. We don't have time to go into it, but you could become a larger entity through what we call just a legal merger and really keep individual divisions vis-a-vis the practices that are currently in existence prior to the merger intact. And yet, as a single provider number, you would have one voice in order to deal with whatever is going to come down the pike going forward that we've been talking about. So what we suggest is every single practice should prepare for tomorrow. And having said that, I should emphasize that we're not recommending that you go out as soon as this conference is over, this webinar, and start forming your own clinically integrated network or selling out to the hospital or merging with another group. We're still in a fee-for-service environment. We still think we will be for at least a while, and I would say at least another 18 months or so before the shift really starts to come into play. Clinical integration is more of the final goal. Initial alignment would be the primary strategy and vehicle. Other core competencies will need to be in play here for this to be pulled off, for lack of a better way to put it. Needless to say, there's going to have to be strong leadership, efficiencies in operations that generally equate to cost savings, consolidation of redundant tasks, even redundant clinical processes are going to have to be terminated or ceased or certainly improved upon a great deal. We are going to be looking at managing risk going forward. Now, I've heard a lot, in fact, a lot of people have asked, well, does all this mean we're just going to go back to capitation? I don't think so. I think this is, maybe it's capitation on steroids. Maybe it's entirely different. I do think this time, though, unlike what we experienced in the 80s and 90s, that we're going to have to get serious about managing population health and taking on financial risk as a result of that. That will require case management infrastructure. Now, we experienced some of that under capitation, in fact, a fair amount about it. I remember I worked with a large IPA in the Northeast that was managing about 120,000 lives, all capitated. They employed more case managers than any other single type of employee in that IPA, and for good reason. And by the way, that was 10 or 15 years ago. Today, we're going to be re-looking at some of that. And yet, I don't believe we're looking at capitation per se in the same sense that we experienced, but certainly a different version of it. We're going to have to remain flexible. This isn't etched in stone. There's going to be a lot of changes. I wish I had all the answers. I'd probably be a lot richer than I am if I did, but I don't, and I'm not sure anybody else does either. We are going to have to be nimble, as I use that term quite a bit too, to our clients. Okay, with those thoughts in mind, Amy's going to share with us the last 3 or 4 slides, and then we're going to cover a quick case study, and we'll throw it back for questions. So Amy, talk to us a little bit about the value of value-based models.
Very good. Thanks, Max. As Max alluded to, we are definitely in a fee for volume environment right now, and we anticipate that that will continue, at least in some scope, into the foreseeable future. But there is a growing and increasing focus on this fee for value environment. So what is really in it? What is the value of fee for value for participants? So the first look that we have on slide 29 is the advantages of collaborative. There are a couple of themes that emerge regardless of the structure that you're involved in. The first is that it provides private physicians an opportunity to be competitive without having to give up their independence and autonomy. I referred to it earlier in the webinar, but that is a consistent theme I hear from my private practice clients. I want to continue to have my independence. I want to have my autonomy. And candidly, there's no shame in wanting that. There are a lot of physicians who are excellent at what they do in terms of their clinical skills, who also possess the aptitude to continue to be businessmen or businesswomen that can thrive in an independent environment. There's no shame in that. There's no reason to want to change that. And now there are opportunities to continue to be successful in that structure, even as we move towards a fee-for-value environment. One of the other things that's great about collaboratives is that it allows physicians to have an incentive to provide excellent clinical care and to provide cost-effective care. So many times we've seen that the incentive in a fee-for-volume environment has been just that. It's been on volume. It's been on a churn and burn of patients. Now the incentive structure changes to the point that there are true and meaningful incentives for care coordination, care provision, and cost efficiency. Now the other common theme that I hear from physicians is this really going to be providing me with an incentive for patient outcomes, which means I have to get a patient to stop smoking. It's not about me counseling them about smoking cessation, but it's giving me an incentive when they actually do. And that's not something that I necessarily have control over. I can't take the cigarette out of Sally Jo's mouth. I can only provide her education about what it does to her body. And that's one of the things that we really work towards in developing the metrics that are included in any clinically integrated network, any quality collaborative, is making sure that it really is items that physicians can control. And we believe that's going to be the most successful for participants, both from the provider and patient perspective. One of the other great advantages of collaboratives is that it prepares physicians, private practice physicians particularly, to have a strategy in the event that the government mandates accountable care. So we've seen a lot of great examples of this. We saw it with PQRS. We saw it with meaningful use. We saw that the calm before the storm is that there is a carrot hanging in front of you that provides you a little bit of incentive to get this going. And then there's going to be a reciprocal negative repercussion on the back end for those that haven't taken that incentive. Do I believe that's going to happen in the next 2 to 3 years? I think the government probably has enough on their hands with what they are doing right now in terms of health care for that really and truly to be a mandate in the near term. But I think it's a reality that we should begin to prepare ourselves for. On the next slide, we list some of the benefits specifically for CIN participants, so not just quality collaborative participants, but for those that engage in a CIN strategy. A lot of the same benefits apply. There's greater financial incentives. There can be greater provider stability. We see that obviously there's a focus on quality and value. There's this maintenance of autonomy. But we also see that there's a chance to expand to provide expand patient bases and to collaborate with local partners. And those partners can be very, very broad in a CIN. It can be other providers in the community with whom physicians haven't yet engaged. It can be the local health system or systems, and it can be payers. Again, when we refer to one of the previous slides that we saw, in which there is this true continuum of care, that's what we're aiming to achieve, is a collaboration between all the various stakeholders within our healthcare delivery model. So the key takeaways on the next slide of this presentation are really that the accountable care era is here, it is upon us, and it is coming with a wave of changes. These changes are going to bring challenges for private practices, but they're also going to bring the potential for a lot of rewards. And that's not just rewards for the way that we do things right now, but for stepping forward and moving aggressively towards some of the new paradigms. We see that the potential exists for private practices to continue to be successful, but the reality is that they're not going to be successful without appropriate investment in their IT infrastructure and resources, as well as their primary care base, as well as their administrative infrastructure, etc. So the reality is that while there are challenges, there is the opportunity to overcome these challenges, and there are incentives for those that absolutely are successful in these models. The last thing that I will tell you before I turn it over to Max for our case study is that you don't have to rush out, like Max said, to develop your accountable care organization or your CIN right after this at your 2:01 p.m. But instead, you have to develop a plan for responding to accountable care. And that could mean that you're going to maintain the status quo for a while. It might mean that you have 12 months before you really start investing in one of these initiatives. It may mean that you look for a partner with whom you can align and then engage in various accountable care structures. But it means that you take your future into your own hands and you look for a plan that you can be forthright with, that you can be aggressive in implementing, and that you can ultimately own. So Max, why don't you take it away for our final case study?
Okay, thanks, Amy, and we'll be brief because we want to leave a few minutes for questions and still get finished pretty much on time. This is an example of what we were referring to, and again, I'll just kind of go through it. It's an actual real-life experience, and we actually took a couple of similar type examples and kind of blended them into one case study here. So we have several larger specialty practices. Now, I will say in at least one of the cases it was almost all specialists. The other, it was inclusive of primary care, and clearly you want that primary care ingredient if at all possible. Unfortunately, many of the primary care practices are already employed or aligned with someone else, often employed by a health system. Not saying that's bad. I'm just saying that obviously they're not available. As far as what we looked at was a form of collaborative, as Amy referred to. Now, often, as I stated earlier, this collaborative is really initiated in the form of an independent practice association. It can be formed relatively inexpensively. It doesn't really create a lot of waves, as it were. Now, I will say this, it doesn't really give you a lot either. It's not clinically integrated at that point, and so you are limited. You can spin off and create purchasing entities and or management companies. I was talking with an interested party just yesterday in the Midwest, and their impetus was to try to create this type of, quote, NUCO, end quote, so they could get some economies of scale purchasing. And of course, one of the questions was, well, can we get contracting power out of this? And of course, the answer is no, not unless you're clinically integrated or if you merged. They were talking about several groups of a single specialist, and I said the simplest thing you can do is merge. And they said, well, we don't really get along very well to merge, or we're not clinically alike. And I said, well, then you can't merge probably, but you could look to form an IPA and eventually move into some sort of a collaborative, or CIN as we call them, if and when you feel it's needed. So that's a strategy. It's relatively inexpensive to do. In this particular instance, that's what we looked at. And I didn't tell you this, but this was a conglomeration of several specialties: OB, general surgery, orthopedics, ENT, urology, GI come to mind. And then, of course, one of them, I'm kind of merging a couple here, had primary care. So the approach was to really look at all of the functional things that we need to consider, from financial, operational, technology. We even built an initial budget of what we think this would look like. And from that, really did an initial planning or integration steering committee, working group type structure to vet out exactly what this consortium wanted to do. The final outcome of this was to create, as we say there in the slide, a hands-on strategy with the client for them to initially pull together in some sort of a NUCO, like an IPA, with the idea and the concepts that they would take it one step further if needed when the market dictated that. So initially it was a fairly limited, frankly it was a fairly limited review on our part, which would not entail a significant cost. And I tried to point that out, that that's not what, that the client did not need that any more than that. They just needed an initial strategy and pull together a collaborative type entity, legally formed, I might add, but really not do a great deal more than that at this point. And that's in fact what they did. That's what we're looking at in several instances as we're working with similar situations just coming up in the last few weeks in our consulting business and practice. And so again, with those possible examples in mind, as well as the previous statements that we've had, let's throw it back. Trish, if you've got a few questions, Amy and I have a few minutes that we'll be happy to entertain them.
Great, thanks, guys. We do have a couple questions that have come in. Let's just get started with, is there any advantage or disadvantage to joining more than one CIN?
Well, the advantage would be obviously if the CIN is contracting with multiple payers or multiple health systems, it might be an advantage. The problem you would have is that may not be the case. They may be, you know, it's the same payers in the community, so you're going to have to decide. The other disadvantage would be that, you know, is just the sheer cost of being involved in those. And like I said, the biggest disadvantage would probably be unless they're very compartmentalized and separated for the payer contracting as well as the health systems, then it would probably be overly complicated and, quite frankly, unnecessary to be a part of multiple CINs.
Okay, and how do we, as we form a surgical specialty CIN, engage primary care docs, all of whom are owned by hospital systems?
Well, very difficult. Amy, I'm sorry, if you want to answer that, go ahead. Okay, I'll do it. Very difficult to do that. Frankly, the answer to that is if there are no primary care that are not employed, then your choice will be to contract through your CIN with the hospital CIN, and that's okay. I told a group last week in a somewhat analogous situation that, you know, you're going to contract or be employed by a health system at some point in your future. You can either do it through your own CIN or you can do it through employment, which again is okay if that's your choice. But in this instance, if they have all of the primary care, then you really do need to have a contractual relationship with their clinically integrated network, so you do have that linkage to the primary care and obviously the referral base. So that's not a real big negative. The reason I said a moment ago that it'd be nice to have primary care is obviously it gives you more independence and more freedom absent a health system, but it's not absolutely imperative.
Okay, the next one, where do you see urgent care fitting into this continuum? It is typically staffed by primary care docs, but it is not primary care. Have you ever worked with any urgent care groups?
It's interesting. We just were talking in the last couple of days about staffing for a series of urgent care facilities that were being set up and staffed by an employed physician network of one of our hospital clients. Urgent care definitely has a role. Obviously, one of the most significant is that it affords the opportunity to keep people out of the emergency room. Obviously, that can result in lower costs in the overall continuum of care. So we definitely see the opportunity for urgent care to be included within this system. And to the point that it involves primary care physicians as being the staffers, we absolutely see that as true. We often see it as mid-level providers that are engaged in the urgent care provision, either independently or being supervised by a physician, depending on the staffing model. So we see that as being a very real and necessary part of this process. Obviously, the way to engage physicians in this process is to have competent providers who staff the urgent care, who make sure that patients are referred back to their own physicians after that episode of care or sent on to the emergency department if such a need exists. And so really having qualified individuals that staff those urgent cares is typically the greatest recipe for success that we see as part of the delivery system.
Great, thanks, Amy. Let's just do one more question here. If I want to get a group of practices together to work towards alignment, what would be my first steps?
I think the first steps, and I'll let Amy jump in here too in a moment, but the first step would be simply to have a meeting or two. I mean, it's just that simple, and it's very innocuous. It doesn't have to be threatening. You're not merging, and you make it very clear, and then you really have, you may need a facilitator if you feel like you don't really have the level of understanding that you might need, someone who could come in and give you a little bit more of an overview of what the options are. But I think really just sitting down at the table with representatives, I know in the Vikings project example, the case study, that's exactly what they had done. They had come together with those large specialty group leaders, and by the way, it was physicians. It wasn't just the administrators of that group. It was primarily physician-led, which I thought was extremely refreshing. And then after a certain point in time, they did a consultant vetting, and we were fortunate enough to be selected. And then from there, I'll just quickly say, we don't recommend that there be a lot of extensive cost and formulation of legal and consulting fees. We typically recommend what we call a brief, we call it kind of a landscape review. In other words, just to really do a brief evaluation of what is in play, you know, who the players could be, how serious they really are, what it would look like, who are the hospital players in the community that we would ultimately deal with, who are the private payers that we would deal with, and then really tee up before you get to the formal business plan, but really tee up what needs to be done, and maybe even go so far as we did with the Vikings project and actually form a legal collaborative entity. Amy, do you want to embellish on that any?
I think that's well said. I mean, I think that just getting the organizations together to look at whatever your alignment strategy is going to be. In this case, I'll assume it's a group of, you know, multi-specialty or single specialty practices. Just having that conversation about what everyone's realistic goals. And if it is limited to a group of specialists or specialty groups, really having that conversation about how you're going to engage primary care as part of your strategy, because again, we do see that as being a vital part of the overall process.
Okay, great. I know I said that was the last question, but one more popped up that I think would be a good one for you to answer, particularly for the group of folks that we have on the line. How about bringing on board non-employed specialists but are hospital-centric, such as pathologists, radiologists, and anesthesiologists?
I think that will be possible if they're private, but more than likely you're going to be looking at hospital-based specialists, the ones you cited, as well as the employed physicians, such as primary care and any other specialty, ambulatory-oriented specialty, I think those are the individuals that will be a part of that circle under the hospital side of things. In our three-legged stool, you know, we are looking at the physician, CIN, private entity, the hospital entity, which would be comprised of those individuals you cited as well as the employed physicians, and then last but not least, pretty much all the other providers from home health to others, obviously, that fit the full continuum. So I think that's okay. If you do have some of those specialists that are available and able through no prohibition on their contract with the hospital to be a part of your CIN, they certainly could be, but I don't think that's going to be a typical structure.
Okay, great. That was the last question that we had. So thank you, Max and Amy, for a great presentation, and thank you to everybody who joined us today. And as a reminder, we will be getting you a copy of the slides, an audio playback option, and providing Max and Amy's contact information if you would like to reach out to them with any further questions. So everybody, thank you, and have a great day.